Bismillahirrahmanirrahim. I'm Dr. Abdul Rahman and we are learning Ecg. In the previous videos, we have already discussed about P wave, different morphologies of P wave, atrial depolarization, short P wave, tall P wave, bifid P waves, and different abnormalities. After that, we discussed about PR interval. We have discussed about different types of heart blocks and supraventricular tachycardias, AVRT, AVNRT, WBW syndrome, atrial fibrillation, like that. And now it is the time to learn about Q waves. We know that Q waves are generated by septal depolarization. What is meant by septal depolarization? We know, for example, this is our normal heart, this is SA node, this is AV node. So after impulse is generated in the SA node, it depolarizes both of the atria, and impulse reaches the AV node, and after AV node it goes to bundle of His, then right and left bundle branches. So from here to here, actually it is demonstrated by P wave, which we demonstrate atrial depolarization followed by a flat line, which is PR segment, and this flat line PR segment demonstrates delay in the AV node. After that, there is small negative deflection. This negative deflection is actually the Q wave, and this negative deflection actually it demonstrates septal depolarization. This will be followed by ventricular depolarization demonstrated by QRS complex, and then ventricular repolarization demonstrated by T wave, followed by Purkinje fiber repolarization demonstrated by U wave. We have already discussed that, and we have already overviewed actually. So Q waves, they demonstrate this septal depolarization. Okay, so Q waves can be physiological as well as pathological. So physiological P waves, we can see sometimes Q waves are not evident every time in every lead, but sometimes we can see some Q waves which are physiological, which does not show any pathology. But other time we can see pathological Q waves, and that is why we need to learn about that, and we need to differentiate between physiological and pathological Q waves. And pathological Q wave can be due to three reasons. Either it is due to abnormal conduction, like some conduction tissue is abnormal, for example bundle branch block. It can be due to some abnormal structure, especially hypertrophic cardiomyopathy, and sometimes it is due to myocardial tissue damage, and myocardial tissue damage, for example in myocardial infarction, or myocardial tissue replacement, for example if normal conducting tissue is replaced by amyloid tissue, or there is sarcoidosis, or there is fibrosis of normal heart tissue. Okay, so this this was just an overview of what we are going to learn in this ECG in this video. Let's go to our whiteboard. So let's take them one by one. For example, start with physiological Q waves. Okay, so normal physiological Q waves. So Q waves are a normal phenomena in the heart. Septal depolarization is a normal phenomena, and we can see the Q wave in some of the leads. For example, this is our normal heart. Okay, this is SA node, this is AV node. What happens normally? Impulse generation SA node, it depolarizes the atria, it reaches the AV node. There is an AV nodal delay, which is demonstrated by PR segment, followed by a bundle of His, and then it depolarizes right and left bundle branches. Go to right and left bundle branch, which depolarize right and left ventricles. During this process, septum is depolarized before the depolarization of the ventricle, and septum is depolarized from left to right side, because left side of the septum is depolarized earlier, usually because of a little bit faster left bundle branch. Okay, so left part of the septum is depolarized earlier, and that is why then depolarization wave is from left to right side. This is normal depolarization of the septum. So when it is from left to right side, that is why in the lateral leads, which are lead AVL, lead 1 and lead, not 2 but lead 1 and lead AVL, these are lateral leads. Similarly, V1, V2, V3, V4, V5, V6, these are the chest leads. So V5, V5, 6 and lead 1 and AVL. So in these lateral leads we can see a negative deflection. So for example, I am seeing the ECG from lead 6. So I am seeing the heart from this side, for example, and what will happen, I will see a normal P wave, then PR interval, and then a negative deflection, which is actually this negative deflection, because atria was a septum was depolarizing from left to right side, while ventricle is depolarizing from inner to outer side. We know that already. Okay, so this depolarization of the septum will be demonstrated as a negative deflection, which will be a Q wave, and we can only see in the lateral leads because it goes away from the lateral leads, not other leads. Okay, and then there will be a normal QRS complex, which is due to these depolarizations of the ventricle going from inner side to the outer side, and then T wave and then U wave possibly. Okay, so this negative deflection, first physiologically we can see this negative deflection in lateral leads. Okay, and a second type of Q wave which can also be normal, it is in case of lead 3. So lead 3 is here. So usually it should not appear in the inferior leads or in lead anterior leads, because these leads are usually in line with the Q wave. When I say in line, actually this is a 2D image of the heart. So if we see the heart from above, for example, this is a man, this is his head, and these are his arms. Okay, and this is his nose. So we are looking the heart from above. So how will it appear? So it will appear like this. Okay, this will be right ventricle, this will be left ventricle, and this will be right atrium, left atrium. Okay, so this will be the normal heart, and the position of normal heart will change with the body position and especially with respiratory movement. For example, during inspiration, when lungs will come down, the heart will be more like this. Okay, heart will be more anterior, so this shape of the heart will be most likely during inspiration. Okay, for example, this man is inspiring, so when it will be taking breath inside, so what is happening, Q wave, the septal depolarization is happening like this. Okay, so our lead 3 is here. So what does it mean? It will be more in line with lead 3. It is directly going to lead 3. So that is why during inspiration the Q waves in lead 3 usually they disappear. But when the same person is expiring, then the heart shape is like this. Heart become more horizontal. So right ventricle comes here, left ventricle is here, and now the depolarization is like this. Okay, and lead 3 is here. Okay, and now it is going a little bit away, not totally away, but it is going away. Previously it was here, now it is here. So it is going a little bit away from the lead 3, and this can lead to generation of small Q waves in lead 3. So that is why the Q waves which appear only in lead 3, if the Q waves are appearing only in lead 3, not other inferior leads, not in lead 2 and AVF. If Q wave is there in lead 2, 3, AVF, then it is not a physiological Q wave. It means that there is some problem in the inferior wall. But if Q wave is present only in lead 3, and that Q wave is changing its size with respiratory movement, that is also a physiological Q wave, and that Q wave usually we call it respiratory Q wave. Okay, because it disappeared during inspiration, because during inspiration heart is more in line, heart is more horizontal, and Q wave are more in line with lead 3, while during expiration heart is more horizontal, and that Q waves are depolarization, normal septal depolarization is going away from the lead 3. So there are two types of physiological Q waves which we can see. First in the lateral leads, In later leads, normally we can see small Q waves, and in lead 3, during expiration, we can see small Q waves. So there is also a criteria of differentiating pathological Q wave from physiological Q wave depending on the size. So normal Q wave, it should be maximum of 2 small square deep, okay, depth will be 2 small square and 1 small square wide, or you can say 2 millimeter deep and 1 millimeter wide. So if any Q wave is more than 1 small square wide, if more than 1 small square wide, it will not be normal Q wave. Or if Q wave is very deep, it is more than 2 millimeter deep or 2 small square deep, again this is not a normal Q wave, it will be a pathological Q wave. So in these physiological Q wave, they should be not more than 1 millimeter wide and not more than 2 millimeter deep. But if they are deeper than this cutoff or wider than this cutoff, again they will not be normal. So this was all about normal physiological or positional Q waves. Okay, yeah. So now let's go to some pathology in the Q wave. So first pathology, we have learned that abnormal conduction. Okay, this abnormal conduction, actually in this portion I will cover not the appearance of Q wave, I will cover the disappearance of normal Q wave. So as I told you earlier, what was happening, normally septal depolarization was from left to right side, while ventricular depolarization was from inner to outer side. And why septal depolarization was left to right side? Because of left bundle branch, which is bigger than the right bundle branch, and which depolarizes left part of septum earlier. So for example, in some condition, if my left bundle branch is blocked, what will happen? The right side of heart will be depolarized earlier. Similarly, the right side of septum will be depolarized earlier and left side will be left away. Then after depolarization of the right side, then the left side will be depolarized and there will be a reversal in the direction of septal depolarization. Now the septum will be depolarized from right to left side. When septum is also depolarizing from right to left side, and ventricle is also being depolarized from inner to outer, which is also right to left side, then in these leads we will not see, in the lateral leads, the leads I mentioned above, V5, V6, 1 and AVL, in these leads we will not see a normal negative P wave, negative Q wave. We will see just QRS complex. There will be loss of normal Q wave. When it will happen? It will happen in left bundle branch block. So this is a type of conduction problem in which we will lose normal negative Q wave. Okay, so again the loss of this normal Q wave is, they will show an abnormality which is left bundle branch block. Okay, second type of condition in which there will be some abnormality in the Q wave, we discussed, that was abnormal structure. Okay, abnormal structure means abnormal anatomy, and in this topic we will discuss hypertrophic cardiomyopathy. Okay, what happened in hypertrophic cardiomyopathy? Actually the septum become enlarged. Okay, previously what was happening, the septum was of very small size. I will draw two hearts. Okay, then I will explain you. So this is a normal heart and this is normal conduction. Okay, so due to this, because the septal wave, septal depolarization was very small, that is why there was a small Q wave followed by normal big QRS complexes. But what will happen in septal and hypertrophy? There will be huge vectors going from left to right, and again there will be huge vector going from right to left for ventricular depolarization. So because these are huge waves, huge vector going away from the lateral leads, we will see very deep Q waves, very deep, but they will not be wide, because there is no delay in the conduction. There is a faster conduction. If there is a delay in the conduction, Q wave will be wider, okay. But if it is an increased amplitude of the conduction, increased current but not delay, increased voltage, you can say, it will be deep, not wide. So they will be a deeper Q wave, but they will be very small, not wider Q wave. So these deep Q waves, sometimes it looks like a dagger, okay. So these dagger shaped Q waves, mostly seen in the lateral leads, they will demonstrate that there is a septal hypertrophy, and that is most very pathognomic factor in the ECG findings of hypertrophic obstructive cardiomyopathy. Because in hypertrophic obstructive cardiomyopathy there will be enlarged hypertrophy of the septum, which can cause sometime obstruction as well in the outflow tract. So if we see a very deep Q wave, deep means deeper than 2 millimeter. If we see deeper than 2 millimeter Q wave, which are not wide, which are dagger shaped, sharp like a knife, so this will be a pathognomic finding in the ECG of hypertrophic obstructive cardiomyopathy. There is a special now there is a special type of hypertrophic cardiomyopathy in which only the apex is hypertrophied, but septum size is normal. That has nothing to do with Q wave, but I'm discussing it because we are discussing hypertrophic cardiomyopathy. And this type of cardiomyopathy in which there is apical hypertrophy, we call it is having a special name, I forgot, but Yamaguchi syndrome. It is called Yamaguchi syndrome. Okay, so this Yamaguchi syndrome is actually apical hypertrophy. The hypertrophy will be only in the apex. That is why in this type of hypertrophic cardiomyopathy there will be no Q wave abnormality. Okay, there will be no Q wave abnormality, but the pathognomic factor in the ECG will be a deep T wave inversion, okay, because there will be a problem in ventricular repolarization because of a huge apex, okay. But because there is no problem in the septum, therefore there will be no problem in the Q waves. So in case of apical hypertrophy there will be a deep T wave inversion. In case of septal hypertrophy there will be a deep Q wave, dagger shaped Q wave. So this is called Yamaguchi syndrome. And another finding, just for your interest, in Yamaguchi syndrome is a significant finding in the echocardiography. We will discuss later on. It is like an ace of spades. You can find this type of picture in the like an ace of spades sign in the echocardiography or ventriculogram or MRI. I will show you the images later on. So this was about abnormal structure. So this the third cause of Q wave abnormality is myocardial damage or myocardial tissue replacement. That is also myocardial damage. So myocardial damage, most common cause is myocardial infarction. So in myocardial infarction, again we see Q waves in certain leads. So what is the basis of seeing Q waves in those leads? Let me explain you. So what happened in myocardial infarction? So normally, as I told you, so this was septal depolarization, this was ventricular depolarization, and there was very small Q wave in lateral leads, but they were not significant. And because the Q wave was opposed by this vector was opposed by huge vectors going opposite to that, okay. So there was a very small insignificant Q wave usually. And similarly in case of inferior leads there was even no Q wave okay, because first it was perpendicular to that, and second the vector is very big, and that was just cancelling out the Q wave negative deflection. So there was no Q wave or very small Q wave in the lateral leads. But what happened in myocardial infarction? In myocardial infarction, actually we lose some part of myocardium. For example, if we lose this part of the heart, okay, so what will happen for so yeah, so what will happen, this part of the heart will be lost, okay. And then if after this happen, if I see the heart from this side, I will not see any opposing QRS, any opposing depolarization. That is why I can see only the Q waves. And if I see heart from here, what I will see a deep Q wave and wider Q wave, because now the conduction is delayed, because the myocardial tissue is damaged. Now conduction is delayed, it will be deep because there is no opposing depolarization, and plus it will be wider and then normal QRS complex, because the neighboring tissue is normally conducting. So there will be a deep and wide QRS complex. In case of ischemia, mostly it is wider because the conduction is delayed, because the tissue is lost. Previously it was small because, for example, if 1 milliampere is going to this side, then 10 milliampere was going to this side. So this 10 milliampere was cancelling 1 milliampere effect, and that is why only small Q wave we were seeing. But now after the damage, then for example, same 1 milliampere is going to this side, but in this side there is only, you can say, 5 milliampere is going to this side. So now the difference is less, and that is why the Q wave will be more prominent, it will be more wider, and it will be more deeper, mostly wider in case of myocardial infarction. So that is why in MI, when the tissue is damaged, after some time we will see appearance of Q wave. When Q wave will appear, it means that the tissue is already lost and the myocardial infarction is old. Okay, similarly in the inferior leads, if this area of heart is damaged, okay, and this area is you can say like this, then there will be no outward conduction. Again, these 10 milliamperes will be lost, and we can see the Q waves now clearly, and there will be appearance of Q wave in the inferior lead. So if you see appearance of Q wave in inferior leads, 2-3 AVF or lateral leads which are not normal, which are wider and deeper than the normal Q waves, it will be abnormal, and mostly it shows the myocardial infarction or myocardial damage. And similarly, if the same thing happen, for example, in amyloid, if there is amyloid deposition in this area, again the conduction of this area will be slowed down, and then again the slower conduction will be demonstrated as a wider QRS complex. Similarly, if this area is fibrosed, again the conduction will be slowed down, and again we will see the finding of deeper and wider Q wave. So these were all abnormalities about different normal and abnormal Q waves. So let's discuss some ECGs. So this ECG, you can see there is normal sinus rhythm, because every P wave is followed by QRS complex, and every QRS complex is preceded by P wave. There is normal XA, because both 1, 3 and AVF are positive. So let's see about Q waves. So you can see some, first of all, in lateral leads you can see small Q waves in the lateral lead, especially in V4, V6. These are just normal Q waves, okay. And similarly you can see small Q waves in lead 3 to 3 AVF, okay. So these are also looks like normal, because they are not more than 2 small square deep and not more than 1 small square wide. So either they can be normal or they can be abnormal if they are if they were deeper than the two small scale, but they are not deeper than two small scale, so most likely they are normal. What we can do, we can ask the patient to take a deep breath and hold it, and then take an ECG. If these Q waves disappear, most likely it will be normal. So this ECG was a normal ECG. Okay. So let's see this one. So in this ECG we can see there is a clearly left bundle branch block. Why is that? Because there is W pattern in V1 and there is M pattern in V6. So we have a formula, maybe we will discuss later on, but we have a formula, William. Okay, so if W pattern is present in V1 and M pattern in V6, it will be left bundle branch block. Anyhow, so this is a left bundle branch block. There is a problem in the conduction, and you can see there is loss of P wave. There is no loss of Q wave. So there is no Q waves in the lateral lead. So that shows a conduction problem. So this is a left bundle branch block. So similarly, I have another ECG. Again, this is W pattern here, M pattern here. This is our LBB wide QRS complex, and there is again loss of Q waves in the lateral leads. Okay, and what about this one? So this is in this ECG we can see very deep T waves. There is big QRS complexes, okay, and deep T waves. So this was the ECG of apical hypertrophy. This is hypertrophic cardiomyopathy, apical hypertrophy, deep T waves with huge QRS complexes. Huge QRS complex shows hypertrophy, okay, and deep T wave shows apical hypertrophy, okay, but there was no abnormality in the Q waves. Okay, this is the thing I explained you earlier. So in this one, what we can see, in this one you can see a deep dagger shaped narrow deep Q waves. You see the Q wave is very deep. It is almost 5 small square or 5 millimeter. There is ventricular hypertrophy. There are deep dagger shaped Q waves in the inferior and lateral leads, and this is hypertrophic cardiomyopathy. Okay, so let's see another ECG. So in this ECG again, this is apical hypertrophy. There is no Q waves, but there is very deep symmetrical deep T wave inversion, mostly in the anterior and lateral leads, and this is again apical hypertrophy, one of the type of hypertrophic cardiomyopathy. And this is which I told you, the ace of spade sign. If you see, this is almost the ace of spade. This is left ventricle, this is apex, which is hypertrophied. This is the one of the echo image. Again there is another echo image. You can see this ace of spade sign, and this is apex, which is hypertrophied, but septum is normal. Again this one not very good, but a little bit ace of spade. Again the apex is enlarged. So these and again this one you can see ace of spade sign in one of the MRI image. So let's discuss this last ECG. What is happening here? There are Q waves which are deep as well as wide, okay, along with there is ST elevation. So what is it showing? Even in the AVF there is deep Q wave, there is wide Q wave, and ST elevation. So this is inferior wall MI with Q wave formation. Okay, so Q waves are there, it shows ischemia. Okay, so that is all for this Q waves.